Hello and welcome to tonight's Dr. Michael Spivak Fall Series lecture. I'm Lisa Marie Sauvé. I am a clinical psychologist who works with children, teens, and older adults in the area of anxiety and depression and other psychological disorders. I'm here tonight to speak to you about sleep problems. So without further ado, let's start the presentation. So this presentation tonight is entitled Sweet Dreams, Sleep Well with Cognitive Behavior Therapy for Insomnia, or CBTI. So why talk about sleep? I think that during these trying times that we are going through, sleep problems are becoming more and more rampant, and I think it is extremely important for our physical and mental health to know a bit more about how to confront these problems and possibly treat them. So let's start by an outline. If we want to know about disordered sleep and what we can do about it, we need to know first a little bit more about what normal sleep looks like to be able to compare. So we'll talk a little bit about that. Then we'll cover insomnia and its causes. We'll also talk about how to set proper sleep goals for ourselves and hold a sleep diary or log. I will give you some sleep hygiene tips. We will talk about something called cognitive restructuring, which is a technique that we use for several things in CBT, but that is often used when it comes to sleep problems or in CBTI. And I'll also cover briefly sleep restriction, which is a technique that is used sometimes to reset people's internal circadian biological clocks. So without further ado, let's start. So what is normal sleep? We know that we spend about a third of our lives sleeping, which is obviously a lot of time. So it's important to know and dig a little bit about what happens and some of the mysteries that have been uncovered from sleep researchers all over the world. So let's start a little bit about talking about what normal sleep looks like and what are different kinds of sleep. So what we know is that there are two types of sleep that researchers have identified. The first type is called rapid eye movement, or REM sleep. And the second type is called non-rapid eye movement sleep. So what do we mean when we say rapid eye movement sleep? So it's called rapid eye movement because researchers have identified that when people enter that stage of sleep with their eyes closed, you can see their eyes going sometimes very rapidly in a saccade from left to right. And during that stage of sleep, our brain is extremely active, often even more so than when we're awake, and our body is put in a paralyzed or semi-paralyzed state, so we cannot move our bodies very much. So in non-REM sleep, the opposite happens. So our body can move, and our brain is in a very relaxed, very calm state. So in stage one being the first stage of sleep, obviously, it lasts only a few minutes, and it's very light sleep where we can be woken up or brought back to our wake state by a sound or by somebody moving in the bed, for example. Stage two accounts for close to 50% of our total sleep time and is a more profound state of relaxation. When it comes to stage 3 and 4, they account for about 20% of total sleep time, and they are even deeper and more relaxing. When it comes to REM sleep, rapid eye movement sleep, we know that there is even more blood to the brain and more brain activity, as I said before, than when we are awake. Our blood pressure and heart rate fluctuates quite a bit, and our temperature is really not regulated. It keeps going up and down. So there is a lot of brain activity and a lot of neurological patterns that occur in REM sleep that never occur when we are in a state of awakeness. So you can see here at the bottom, we have what's called an histogram of sleep. So éveil meaning when we are awake, paradoxal meaning we are in REM sleep. So you can see that from 1 to 8 hours of sleep, we go from being awake to going down in the first hour down to stage 1, stage 2, stage 3, stage 4, and then working our way back up to stage 3, 2, 1 REM sleep. And we have in a normal night about 5 or so of these non-REM, REM cycles. And the intensity and time of the REM cycles increase over the 5 cycles, where we have more REM sleep at the end of the night than we do at the beginning of the night. So this is what a normal person's sleep pattern would look like. So what we know about normal sleep is that in the 1960s, people slept about 7 to 8.5 hours. Today, we count that about 50% of the population sleeps less than 7 hours. And what happens during normal human development is that the efficiency and the quality of our sleep, and even the amount of hours that we normally sleep, fluctuate through our lifetime. So across our lifespan, the percent of time spent in each sleep stage varies quite a bit, with us having more deep sleep when we are younger and moving towards more light sleep as we grow older. So what is non-REM and REM sleep associated with, or what is their function? So non-REM sleep has been recognized to be mostly about physical restoration. So this is when our body gets rejuvenated, it is relaxed, our muscles get to be, how could I say, in a deep state of relaxation while gently moving. So it is where we get rid basically of our aches and pains. And normal processes of cell rejuvenation, etc., and the cleansing processes of our body happen in that state. When it comes to REM sleep, there's a lot of information processing. So during rapid eye movement sleep, whatever new information we have learned, for example, if we're learning a new language, this is when it would be activated in our brain. And there's also a lot of emotional material that's being processed during that state. So if we are in a deeply distressed state during our hours of the day when we are awake, definitely at night during REM sleep, some of that emotional material is going to be coming back up to the surface, and we will dream about it. So if we are missing one specific stage, for example, if we are deprived and woken up and are missing stage 3 or 4, for example, of deep sleep, what will happen is that we will have a rebound effect later on, which we will basically start where we left off. So if we were deprived of stage 3 and 4, in our later sleep, when we catch up on our sleep, we will spend more time in stages 3 and 4 to compensate. We also know that the content of dreams can be affected by what goes on in our daily lives. There was a study by Ms. Rosalind Cartwright, who's a sleep researcher, who studied the difference between recently divorced people who are coping well with difficulties in their divorce, and some who were not coping well with this very stressful situation. And we know that people who were divorced and were depressed had really more pessimistic dreams with feelings of guilt, helplessness, and low self-esteem, while people who were coping better had dreams in which they felt in control and had a better self-image. Our dreams reflect basically our current moods, perhaps in an effort to regulate or process emotions better. So let's talk about insomnia and its causes. So the diagnosis of insomnia is the following. We have to have difficulty falling asleep or staying asleep. It needs to take regularly more than 30 minutes for us to fall asleep or fall back to sleep. We have to have a total sleep duration that is of less than 6.5 hours or so, and the sleep efficiency, which I will talk about later, that's less than 85%. This needs to happen 3 nights or more per week for at least a month. And the most important part of this diagnosis is that if someone, for example, has all of these criteria, but it never interferes with their functioning, which means that they're perfectly well adapted and are able to go to work, tend to family responsibilities, and they feel great, then we cannot diagnose insomnia. It is only diagnosed if this interferes significantly with one's functioning. So what are the causes of insomnia? So there are two essential components to insomnia also that I need to mention. These sleep difficulties obviously need to occur despite adequate opportunities for normal sleep. So someone who, for example, is not able to sleep because of work duties or other instances that really keep them from sleep, we'll be able maybe to diagnose sleep deprivation, but it won't be insomnia because the person isn't trying to sleep, they're just lacking sleep. We also need to have significant daytime impairment that results from what we can assess from that poor sleep quality or duration. There are also two factors that we need to keep in mind. This can be short-term. So there can be what's called short-term insomnia that lasts for less than 3 times a week for 3 months. And very rarely, some people have fewer disturbances than that, let's say once a week or twice a week for 3 months, and then we will very rarely diagnose what's called other insomnia. When it comes to chronic insomnia, we see someone who has at least 3 times a week for 3 months and more. The categories of insomnia are usually the following. So we can diagnose sleep onset insomnia, which is difficulty falling asleep. There's also what's called sleep maintenance insomnia, which is difficulty remaining asleep. And often what people will report is mixed insomnia, which is difficulty falling and staying asleep. In a survey of 2,000 Quebecers by Dr. Charles Morin in 2009, 25% of Quebecers said they were dissatisfied with their sleep, 30% said they had occasional symptoms of insomnia, and 10% of Quebecers reported chronic insomnia. Of all these people, only 40% of people reported seeking help for these issues. And what we know is that there's a very high cost to society of not sleeping well and having what we call proper insomnia. And what we know is that this high cost includes medication, natural and not, and prescription medication, but also medical visits and treatments. Around 200 million a year is attributed to insomnia-related problems. Per insomniac, this in Quebec, this relates or equates to $4,400 per insomniac in Quebec, cost per year. So there's a common belief that needs to be debunked, however, about insomnia, its causes, its effects. There is no direct causal link between insomnia and physical illness, as many people believe. A lot of people believe that if they have poor sleep, that they will get physically ill from it, either in a relative short term or in the long term. Although this has been proven in animals, it is yet to be proven in humans. There are vulnerability factors when it comes to insomnia. So being someone who is usually what we call hyperactivated on the mental and physical state. So some hyperactivity, for example, in the case of ADHD, is definitely a vulnerability factor. Having a tendency to ruminate or having perfectionistic tendencies is definitely something that makes someone more liable to have insomnia. A tendency to want to repress or avoid emotions is also a vulnerability factor for sleep problems. Definitely medical or psychological problems, which we will get into after, such as for medical problems, obviously pain or types of illnesses. In psychological problems, anxiety, depression, panic disorder, all of these can cause insomnia in the short or long term. Another vulnerability factor, unfortunately, is being a woman or being someone who is older, let's say above the age of 60 years old. And also having a family history of insomnia has been shown to give people a genetic predisposition. So what are the causes of insomnia? So we know that psychological stress is definitely something that can induce difficulty with sleep. So either stress, what I wrote here as being stress. So for example, the COVID-19 pandemic is a great example of a stress. So, or of causing stress in people. So stress is the amount of strain that someone can withhold without mentally, that causes mental strain or difficulties. So stress is pressure, it's external pressure from environments, situations, and stressors are the factors that actually make us feel this pressure. So as I said, the pandemic and confinement we've gone through are definitely stressors and have caused stress or strain, pressure in individuals. Anxiety in its many forms, depression, as I mentioned before, PTSD, post-traumatic stress disorder, phobic disorder, in which we have phobias about certain things, and of course, panic disorder, and even related psychological disorders like OCD can definitely cause insomnia. And it is important to know that in the case of anxiety and depression, it is often something we diagnose insomnia as, and we use it to also diagnose these specific conditions. So often in their definition in the DSM-5, there will be sleep disturbances. In the case of medical conditions, obviously anything that affects our comfort, but also people have breathing issues like emphysema, COPD, sleep apnea, or heart issues can definitely have insomnia. Certain digestion issues, celiac disease, Crohn's can also, of course, affect sleep. One of the other big causes are hormonal shifts, either in adolescents or in women during our cycle, menstrual cycle. Menopause is also said to, because of the hormonal depletion that happens in women, is definitely known as having insomnia as a side effect or as a symptom. And allergies, just being stuffed up during the night, having difficulty breathing, can also cause insomnia. When it comes to certain medications, a lot of medications, for example, blood pressure medication, beta blockers that are often used in treating blood pressure, diuretics, which cause a urgent need to urinate during the night, can definitely affect sleep. Prostate issues in men also, and medications that go along with that can also cause insomnia. We know that alcohol and of course caffeine in its many forms can definitely cause sleep problems. When we talk about environments, definitely the amount of noise that we are surrounded with, the amount of light that we get in a room, and whether or not we sleep with a partner or not is actually really important. What we've shown is that usually when we start sleeping with someone, there are definitely sleep disturbances that happen with that. British researcher Jim Horn demonstrated that sleeping with a partner causes more movement and interrupted sleep at the beginning, but that partners usually get used to it. That being said, people have longer and less interrupted sleep when they do sleep alone. However, if we have a big enough bed, that definitely can help the issue. So let's talk about how some sleep disturbances that happen to all of us can then become chronic insomnia. So how does temporary insomnia become chronic? we know that this is usually caused by something that's called sleep performance anxiety. So this type of anxiety is usually due to our beliefs and thoughts about sleep, about the quantity we need to have, and about its effects, but also about wanting supreme control over our sleep and how we get to sleep or how we stay asleep, how long we sleep. And definitely has to do with some unhelpful habits that we develop around sleep. So I wanted to show you a chart that shows how this vicious circle of insomnia gets going. So if we start with a precipitating factor, whether it's internal or external, an example of a precipitating factor, an internal one would be a thought or a worry of, I need to do this tomorrow. An external precipitating factor could be having a child and having a baby and having to wake up during the night. So obviously these internal or external factors can cause difficulty sleeping. The problem is when we start worrying about our loss of sleep. This then further causes effort to control sleep, which is where performance anxiety kicks in. And actually what that does is, instead of the efforts helping us get back to sleep and have a better sleep, it does exactly the opposite. We see that there's a worsening of sleep difficulties once we try to control sleep. This is then causing emotional distress, and then this becomes an internal precipitating factor to having even further difficulty sleeping. So how do we break this cycle? So this is where things get interesting. Let's talk about the treatment for insomnia. It's called CBTI. There are also sleep programs that are derived from CBTI or are very close to it and are not specifically called CBTI. We will try to cover most of them today. So there is a self-treatment for insomnia in a book called Vaincre les ennemis du sommeil in French, or Insomnia, How to Vanquish Sleep Difficulties. I will show you the book at the end. So it is a program that was developed at Université de Laval in Quebec City. Its effectiveness over a 6-week treatment has been very well documented. It has shown that 70 or 80% of people that are abiding by the program have seen an increase in the quality and the efficiency of their sleep. 30% of them say they have obtained normal sleep again. But most importantly, 50% have reported notable gains, even if they don't qualify their sleep as being perfectly normal, which is really important. More importantly, even is the 90% of those who use sleep medication regularly and were able to either stop it or reduce it. So all these costs that we were talking about before, basically through this self-help program, were significantly reduced. So a majority of patients after these 6 weeks were able to fall asleep in 30 minutes or less, or even stay awake less than 30 minutes per night. And this was replicated with similar programs across the world, from Duke University in the US, or even the University of Glasgow, through Dr. Ettinger or Dr. Espy. So in the Charles Morin book, there is an entire section about sleep goals. What do we want in terms, and how do we set proper sleep goals? So it is really important to set these goals so that we can measure eventually if we are successful or not. And we then don't have a tendency to overinflate or even underestimate the amount of time that we've been sleeping. In this program, it's also demanded that people record their sleep, the amount of sleep they have, and there are specific pages in the book that I mentioned about that. So Dr. Morin in his book specifies the following measures to be able to quantify the quality of sleep: the latency of time to fall asleep, which means the amount of minutes it takes for someone to fall asleep; the number and duration of awakenings, how many times someone gets awakened at night, the total time in bed versus the total time asleep, which is what we call sleep efficiency. We will talk about it later. And whether or not medication on given nights have been used. So this is what he includes in his sleep records. So let's talk a little bit about sleep hygiene, because obviously it is crucial to better sleep and in the treatment of insomnia. So in his book, Dr. Morin mentions that it's extremely important to have at least 1 hour to relax before bed. With the advent of technology, it's become more and more difficult for people not to answer emails late at night or study if you're a student, or even think about work in a productive capacity, which leaves us very little time to relax. It's really important to have a bedtime ritual. And what do we need by that? We mean that people need to have a certain sequence of steps, usually more than 3 steps, 3 to 5 steps. For example, taking a bath or a shower, putting on their pajamas, reading, doing a few crossword puzzles, and then going to bed, for example. So these rituals from night to night are very important in what we call stimulus control. The third sleep hygiene tip, is to go to bed only when one is sleepy. So a lot of people will go to bed because it is time, quote unquote, to go to bed. This is usually not advisable. So we are only supposed to go to our bed when we are literally falling asleep. If we're unable to sleep after 20 minutes, tip number 4 says to leave our bedroom. So literally to get up from our bed, go do something for about 10, 20 minutes, and then come back once we have started falling asleep or really being drowsy again. Number 5 of the sleep hygiene tips is to wake up always at the same time or very close to the same time, even on weekends, which can be difficult for certain people. Using the bedroom uniquely for sleep and sex. So this means that it is really crucial for people not to watch television from their bed or in their bedroom, if at all possible. If people are able to do that without sleep issues, then it is wonderful for them. But for people who have insomnia, this is strongly discouraged. The number 7 sleep hygiene tip is to not nap during the day. This is the standard form of the treatment. However, I and Dr. Morin and a lot of other psychologists somewhat disagree with that being said. For that reason, just because certain times when people have very little sleep, let's say 5 or 6 hours of sleep, when they are severely depressed or anxious, it does help, especially with the sleep anxiety, performance anxiety portion, to go, it doesn't matter if I don't sleep that much today, I'll be able to catch up tomorrow. The important thing here is to not nap for more than an hour, and definitely not after 3 p.m., which can all affect our ability to then fall asleep the following night. As I said before, number 8 is to limit the time in bed to the time sleeping. So even if we are someone who usually reads in bed, if we start having sleep difficulties, it is better to do that reading or crossword puzzles or Sudokus anywhere else in our house besides in our bed. So obviously for sleep hygiene, other things are very important. For example, limiting our caffeine consumption, especially after 2 or 3 p.m. at night, because it takes about 6 hours for caffeine and alcohol to leave our body. Trying to not go to sleep after an extremely large meal, to not exercise a few hours before bed, let's say 2-3 hours before bed, because those are all things that close to bedtime, nicotine also really increase our metabolism and keep us from sleeping. It is also important, if at all possible, to sleep in a dark, quiet room of moderate temperature. It's been said that a temperature between 15 and 20 degrees is best for sleep. Obviously, a comfortable mattress, if possible. It also helps if the room is not too much in disarray. So if we've put order in our room, and I would add to that, since confinement and a lot of people have started working from home, I think it is important that not a lot of reminders of work and working from home are around our bedroom when we're trying to get to sleep, because it will have us juggle our worries about work while we're trying to relax and go to bed. Exercise can help, but usually we recommend that exercise be done any other time during the day. 30 to 40 minutes of cardio exercise is really good for regular, making sleep more regular. We usually say 3 to 4 times a week, and something that's aerobic and that we can do and just be able to have fun and relax with. However, like I said, just not before bedtime. So now let's talk about cognitive restructuring, which is a technique that's used in cognitive behavior therapy at large, but is also specifically useful in the treatment of insomnia. So in Dr. Chazvani's book, he has an entire inventory of beliefs about sleep that he uses to try to identify the specific beliefs about sleep that cause people's performance anxiety about sleep. So some of these have to do with unrealistic expectations. So a lot of people believe wrongly, because it's been quite mediatized, that people need 8 hours of sleep. So being said, that is an average. So a lot of normal adults can go on having perfectly functional days on 6.5 hours of sleep. Other people might need 9 or 10 hours. So it is really important for people who have difficulty sleeping not to become extremely rigid about needing a specific amount of sleep, like 8 hours, for example. Is really important not to use insomnia as a cause for every mistake or every difficulty we might have had that day. So a lot of people will say, oh, I made a mistake at work. That's because I didn't sleep well. I didn't have my 8 hours. I fought with my partner probably because I didn't sleep well yesterday. So that being said, we have to watch that internal dialogue. We also need to revise the explanation of the cause for insomnia. So for a lot of people, precipitating factors like hormones in, for example, menopause can definitely be the cause for insomnia. However, if we focus on this, and this is how we explain our sleep difficulties, it becomes extremely difficult for us to then feel like we're in control, and this makes us even more worried. So we know that psychological factors, even if they're not the precipitating cause of insomnia, are involved as what we call maintenance factors. And these are the factors that we can control and basically use to break the cycle of insomnia. So we need to be able, for example, to focus on what we do control, learning to deal with the worries and with the pressure that we put on ourselves to sleep. This is what we need to restructure once we have difficulty sleeping. It is extremely important to never try to sleep. A lot of people say, oh, I was tossing and turning. I was really, really trying, because all research shows that this effortful pressure and this undue effort to sleep actually rouses us and stimulates us instead of relaxing us. So it's important, as I said before, to go to sleep when we are already drowsy, not to force it. The important thing is also to manage our intrusive thoughts. A lot of people believe that they have these specific worries about sleep that really make it difficult for them to put those aside. These intrusive thoughts can go from worries about our day to what we have to do the next day, some conflicts that have come up. So we definitely need to know what to do with our worries before we get to sleep, because anxiety right before we are about to fall asleep really is extremely deleterious to our sleep. It's really important also not to dramatize the effect of a bad night of sleep. A lot of us, especially, for example, young parents, have very little sleep that they go on and still are functional people. So it is absolutely possible to have a bad night's sleep and still function very normally the next day, even though it will be probably very difficult and will be more tired. A lot of people dramatize it in the sense that they think, oh, I won't be able to make it through tomorrow. I haven't had a good night's sleep, so I'll probably fail my test, or I'll make a huge mistake at work. So it's important not to do that. It's important also not to put too much importance on sleep and act as a victim. Sleep is really important, just as much as eating and exercising and sex. There are things that are basic needs, but it is not the only thing we need, and it is not the basis for everything. So it is also important to develop a tolerance to some of the effects of insomnia. So one of the things that someone can do when they've had a bad night's sleep or insomnia for a while is to reorganize their day to make it a bit lighter, or even postpone very difficult problem solving or difficult decisions to a time when they are more rested. And finally, we need to prevent relapses, because it is important not to watch actually dramatic interpretation of these occasional difficulties to sleep, so that we don't think that every time we've had a bad night's sleep, for example, that we're back to square one and that we'll have chronic insomnia all over again. This type of thinking just leads to more sleep performance anxiety and more issues. Another essential component of treating insomnia is obviously stress management. One of those first essentials is being able to practice good breathing, deep, relaxing breathing before going to bed. One of those types of breathing is called diaphragmatic breathing or belly breathing, when we train and use the muscle of the diaphragm to basically pull air into the lungs and slowly exhale. Another type of breathing that is very popular is called 4-7-8 breathing, or yogic breathing for a lot of people. And its principle is to inhale slowly on the count of 4, pause or keep air in for 7 seconds, and then slowly exhale for 8 seconds. Other techniques include progressive muscle relaxation, also called Jacobson relaxation, where one successively tenses and then relaxes muscle groups, combine on both sides of the body or on one side or the other, and then proceed to do all of the muscle groups in the body successively. Other things like mental imagery, for example, being able to visualize the happiest day of our lives, or our favorite vacation spot. For a lot of people, doing that instead of counting sheep, for example, is much more efficient. Other techniques like auto-hypnosis, basically repeating certain mantras to ourselves while deeply breathing, or repeating positive affirmations, or even guided meditations right before we go to bed are really useful. And so is, of course, meditation. It's all in all its forms, namely mindfulness meditation, that asks for us to focus on the present moment without judging our experience, whatever is going on. So the next portion of the presentation is about sleep restriction and sleep windows. So to be able to alleviate insomnia, we want to aim, or to have good quality sleep, we want to aim for a sleep efficiency of about 85%. What do we mean by that? Sleep efficiency can be calculated by using the time that we are actually asleep, divided by the time that we are in bed, and multiply it by 100. That being said, for example, if I spend 8.5 hours sleeping out of 10 hours in bed, I would then have, of course, 85% sleep efficiency. I'll try to give you an example. So if someone goes to bed at 10:30 and gets up at 6:30, that would give us a total hour time in bed, of 8 hours. But if that person takes an hour to fall asleep and then spends 1 hour awake during the night, they have basically spent 6 hours sleeping out of that 8 hours in bed. And that sleep efficiency of 6 divided by 8 times 100 is only 75, which is well below 85. So it would be better for that person to go to bed at, let's say, 12:30 at night and sleep right through to 6:30. If that means that they then sleep, let's say, 5.5 hours out of that 6 hours in bed, then they start there. And each night after that, they can roll back the clock 20 minutes earlier, as long as they maintain that 85% efficiency of being awake for most of these 5-6 hours in bed. It is a bit difficult because I call it sleep math, but it can be easily done with sleep logs and then calculated rather easily. So obviously sleep has to do with our circadian and biological clocks. We have many biological cycles as human beings. The one for sleep is called the sleep-wake cycle. It's influenced obviously by light, but also by other social time markers, like the beginning and the end of the workday or meals, for example. There are 2 types of chronotypes that have been identified. So 2 different types of quote unquote sleep-wake cycle people. There are what we call the early risers and the night owls. So an early riser would be someone who feels most energetic and most awake in the early hours of the day, versus someone who has an easy time staying up at night and even staying up late into the early hours of the morning. So we often see certain circadian rhythm problems that have nothing to do with environment or with the amount of noise or whatever is going on in the person's life. And these circadian rhythm problems are usually genetically determined, but also sometimes are a mystery. So the 3 of them that we know most and encounter the most are what we call delayed sleep phase syndrome, advanced sleep phase syndrome, and jet lag. So in delayed sleep phase syndrome, basically the person has a delayed sleep compared to other people. So for example, they will have a tendency to fall asleep more easily around midnight or 1 a.m. instead of at 10 or 11 at night. The advanced sleep phase syndrome is the opposite. So the person will have a lot of difficulty and fall asleep very early in the evening, around 7 or 8, have a lot of difficulty staying up, and be most easily awake in the early hours of the morning. There's also jet lag, obviously, that happens when we change time zones during travel. So the fact of being used to falling asleep, let's say around 11, if we have to go to Europe, for example, and have to be 6 hours ahead, that can cause problems because our biological clock is then usually slow, and we are really not, we are tired when we are not supposed to, basically, or awake when we should be asleep. So ways to address circadian rhythm problems are pretty much light therapy, melatonin, and what's called chronotherapy. So for delayed sleep phase syndrome, usually doing light therapy in the early morning and exposing ourselves to LED lights or lights that have wavelengths that mimic the sun early on in the morning will help people fall asleep faster at night. And the opposite is true for people with advanced sleep onset syndrome, where they would have to expose to light therapy in the early hours of the evening to then be able to stay awake longer. Melatonin can also be used to address these circadian rhythm problems, especially when we have to change times or during, let's say, the time changes that occur during fall or in the spring. So using melatonin is most useful when we basically take our waking time, or the time when we need to get up in the morning, and we try to take melatonin 8 hours before the time where we should be awake and starting our day. And melatonin can be used because it is not a hypnotic, it is not something that induces sleep. It can be used for very occasionally and is seen as a natural supplement. The last way to address circadian rhythm problems is called chronotherapy, and it involves basically advancing someone's sleep time by 3 hours a day. What that does is that on the first day, for example, someone is asked to go to bed instead of 9 p.m. is asked to go to bed at midnight. The next night needs to go to bed at 3 a.m., then 6 a.m. What we do is that we try to go around the clock once, and this can obviously take a few days or even a week or two to completely go through the entire 24-hour cycle. And what that does is that for people with delayed sleep or advanced sleep onset, it basically resets the entire circadian clock so that it is better timed with light cues or with socially determined cues to sleep. So the references that I used to build this presentation was mainly Charles Morin's book from University of Laval called Relief from Insomnia, Getting the Sleep of Your Dreams, or in French, Vaincre les ennemis du sommeil. Other books on sleep from this author is Insomnia, Psychological Assessment and Management. There are other books from Colin Espy or Lisa Meltzer about insomnia and sleep problems. Lisa Meltzer is also an expert in pediatric sleep and developmental psychology and sleep disorders. So thank you very much for sharing this time with me, and I hope this has been a productive presentation that helps you get to know a little bit more that if you have sleep problems, you are not alone, and there is definitely something you can do about it. Thank you. Good night.